Welcome, everyone, to Planetary Health First, Mars Next. Today is a special day for all those out there. It is 420, not to mention anymore, but we got a pharmacist on the show. So anyway, it's so awesome to have you guys here today. And we are going to have a great time with Shawn Nairn. He is a pharmacist, licensed pharmacist. He's an owner of ACAR Pharmacy. I'm not going to get into too many details because we're going to be talking later. But Shawn, if you want to just give a brief, tell us a little bit about yourself.
Thank you, Michael. I appreciate you choosing 420 for me too. That's I don't know what you're trying to say. I really don't know what you're trying to say, where you're trying to go with that, but it is
coincidence. Every week we have it at Thursday. So got to have anyway.
Right. It's good to be here and I appreciate it. So, Mike, I have a pharmacy, and Mike and everybody, I should say, I have a pharmacy in Pittsburgh, ACAR Pharmacy. We specialize in compliance, packaging, and medication adherence. So essentially, if you think of the pill cases that grandma and grandpap use Sunday, Monday, Tuesday, Wednesday, and you're running to their house every Sunday so you can fill their pill case for them, it's that. We send medications to people's houses in prepackaged pill packs with a dosage, breakfast, lunch, dinner, bedtime dosage based on the patient's medication regimen. And we deliver it to them in 4 weekly packages at a time. And essentially that's our model. I mean, what's happening is, as you can imagine, the more people take their medications, the healthier they are, the less healthcare costs go down. And it's taken a long time to get there, but adherence is now at the forefront of, the whole pharmacy thing. For a while, it was get your prescriptions filled, and no one really paid much attention to what happened after that. So now with medication adherence, there's a prompt or an encouragement to improve compliance. So it fits with the pathway that healthcare is on now.
Well, this is great. I was reading, and I know you probably know better, the statistic out there, like medication adherency is like a 50% like no-go. So whether it be so-and-so didn't show up, or the copay, or, I'm sure there's so many barriers. Can you just tell us a little bit about what you see as the biggest barriers to medication adherency?
Well, I'll lead off with another statistic, right? Non-adherence to medications costs the healthcare system $400 billion a year. And that's a 2 or 3 year old statistic. So you could argue it's more than that now. So that's across the whole chain of, that's people going to the hospital, they didn't take their medications, they had an incident. That's people calling off work. That's, that's a whole conglomerate of not taking your medications and all the downstream effects that being sick because of that has. But $400 billion is no joke. I mean, if you can carve into that to any extent, you're making progress. And essentially, again, to your point, saving the system money. You're on a mission to transform healthcare. You're transforming healthcare if you focus on improving medication compliance, thereby reducing cost. So,
and so you're saying that's a year.
That's right. Now, that's just not health insurance expenses. That's people calling off work, and that costs money. There's a variety of figures, facts and figures lumped in there to come up with that number. But that's still a massive number. I mean, I don't care how you slice it, or, so much of it is not taking medications. So much of it is, missing work days because you're sick, missing work days because, you miss a work day because your mother is sick. So now you have to take her to the hospital. She didn't take her meds. You're taking her to the hospital, but now you're missing work because you're the caregiver and you're taking care of your mother or your grandma.
Yeah. So when it's $4 billion, I imagine $400 billion, that includes readmissions, all that. Admitted to the emergency room because you didn't have a refill and you have some major medication that you haven't had. And I imagine some of these, what would happen if you didn't take your blood pressure medication for 2 days?
It's all of that, right? Well, you can imagine, right? Any number of things. I mean, you could have any sort of incident. You could have everything from a stroke to, a fainting episode that causes you to, hit your head. You get dizzy and you fall down the steps. That's true. What about sleeping medicines, right? Non-adherence is sometimes taken. It's also taken too many. It's not adhering to your regimen. So you take a sleeping medication and you still can't sleep, so you take two. Then you pass out and you wake up in the middle of the night to go to the bathroom, and you're dizzy because you took too many pills, and you fall and hit your head. There you go. There's another incident that adds into that number.
Mm-hmm. So Shawn, tell us a little bit about the education component, like how your process works. You have anywhere from 1,500 to 2,000 members that you're providing for. You have a team that goes out and trains, teaches, educates the caregivers on the medications. Tell us about the process. I think our audience would really be interested on that.
Sure. Yeah, man, I'd be happy to. I'll take you soup to nuts. So we market primarily to physicians. A lot of people don't know this, but physicians now have they're a stakeholder in improving medication adherence. Most of the health plans, including CMS, through their star rating system, now reward physicians when they improve adherence across their patient base. So they have metrics that they have to meet. If they do, they have the ability to earn some extra dollars. So again, here's CMS focusing on saying, hey guys, taking your medications is important. Let's incentivize physicians to help patients do this. So we call on physicians, we call on home care agencies and home care nursing companies, because when you think about them, they're witnessing my client firsthand in the home, right? They're in there, they're hired by the family, usually, maybe the insurance company. They're visiting this patient. They know instantly that it's a clusterfuck in there. They can see it. I mean, they live it. They walk in, there's pills all over the place. There's pills from 6 months ago that haven't been taken yet. There's empty bottles, open bottles, and everything in between. There's medicines there that they don't even take anymore. So home care is a good marketing entry point for us. The health plans, to some extent, we kind of talked about this initially. There's some initiative now. Health plans realize if we get people to take their medications, we lower costs. I mean, it's not really rocket science, right? You take your meds, you get on. Medicines are expensive as all get out nowadays, but that does not compare to the treatment of a heart attack or treatment of a stroke or an emergency room visit for a COPD patient. So regardless of the cost of medications, the ability to, getting people to take them is a cost savings center in and of itself. So that's what we do, right? So let me go. So we start off doctors, home care, health plans. They send us a patient. My team then kicks into gear from there. We reach out to the patient. Hey, what medications are you on? Who is your doctor? What pharmacy do you go to now? Tell us a little bit about yourself. And we pull all this information together. We'll call the physician. We call the stakeholders ourselves to verify what the patient says. We call the physician, say, hey, can you send us over a med list of all the patients that, Michael Mann is on, and then of all the medications, that Michael Mann is on. And then we cross-reference that with what the patient told us. And now we're building this profile for the patient. We know how old they are. We know where they live. We know what medications they're on. So from there, then my team, we do the first physical step as a pharmacy is to do a med sync. A med sync is, you can kind of guess what it is if I said the word med sync. It is taking the patient's medications and lining them up so they get all brand new medications on the same day. So that alleviates them running out of one medication and still having other medications, which is a barrier to compliance. So now that we have this med sync date, all the medications are getting ready to start on the same day. We fill all the prescriptions. We package them in our breakfast, lunch, dinner, bedtime packaging. We deliver them to the patient a day or two before their cycle is supposed to begin. My delivery team is skilled and educated. They sit with the patient for, 10, 15 minutes, longer if necessary. They tell them how long, they tell them, here's how the packaging works. Here's what to expect from the pharmacy. Here's when you call us, how you call us. You can expect you can expect a phone call from us in 2 or 3 weeks to initiate the next cycle. So at that point, so the patient gets their medications, are ready to go. We call them 4 days later just to make sure they understand the first time, with the first delivery. We'll call them 3 or 4 days later to make sure that they're comfortable with the process. If they're not, we go back out, redo the introduction meeting. Assuming that they're good with the process, we then, we'll call them 3 weeks later, and the phone call goes like this. Hey, Michael, how have you been? Shawn from Acor Pharmacy. I'm just checking in with you to see how you're doing. You feel good? Your medication's okay? Yes, yes, yes. Have you been to the doctor since we last saw you? Yes or no? Do you have any medication changes that we need to be made aware of before we deliver your next package? No? Okay, great. Well, we have you scheduled for delivery for next Tuesday. Is that going to be okay with you? Are you going to be home? Do we need to move that day? No? Okay, great. We'll see you next Tuesday. And then that's the gist of it. Then they get their package next Tuesday, wash, rinse, repeat the cycle.
Cool. Well, I just want to interrupt 1 second. We have Greg Charlton, who shared a comment that we have. I imagine what he's referring to, your earlier comment, probably is now updated. I don't know what the specific date, but $528 billion is that cost. I imagine he's
Thanks, Greg. That improves my marketing tactics. See how I can leverage your clients to improve my marketing tactics?
And then I don't know what he was mentioning with home health. I'm not sure, but anyway, I can imagine what is the average medication that your members are on, and so what is that amount of medication like how many pills is the average medication that your members are on?
10 prescriptions is my average customer. Now, that might be 1 or 2 insulins. That might be an inhaler. It's not all necessarily oral pills. It's 10 prescriptions. And that's, as much as I'm happy to fill prescriptions, one thing my pharmacy does is analyze. We would like nothing less than to decrease 1 or 2 or 3 prescriptions from people too. That's our obligation as pharmacists. Right? We want to manage medications. I don't want to fill medications. Our goal at Acor is to manage people's medications, right? And if that means cutting 1 or 2, then we're happy to cut 1 or 2. We're the first ones to call a physician and say, why don't we whack these? I mean, I don't think we need these. And, I think there's value in that. We're building this model as a whole team effort, right? I mean, aging at home is the future of getting old. When we work with physicians and home care agencies, I mean, technically, conceptually, I would like to create a nursing home environment in a person's home. And how do we do that, keeping it affordable and achieving the desired outcomes? And that's the battle, right? It's hard to do it all, because while nursing homes are expensive and people don't want to go there, you get economies of scale in a nursing home.
Yeah.
It's hard. One nurse can see 10 people. If I have a nurse at your house, she can see you. That's it.
Yeah.
So that's the missing link. Is how do we figure that out? Is it tell us something? How do we use technology? To figure that out.
So we have some more questions from Greg. And I'm not exactly sure. They're really short. I imagine he wants to know more about diabetes. I guess it's I think it's statin. So statin. Yeah.
Well, I mean, I'm not sure. Yeah, I'm not sure where he's going with that. To your point, with the short answers. I mean, these are all medications that my people are on. My bread and butter patient, let me tell you what my bread and butter patient is, because think about this and it'll make sense. It is primarily a senior, doesn't have to be, but primarily a senior. It can be a mental health patient. It can be a transplant patient. It could be an HIV patient. Anybody who takes a lot of medications, right? But in general, it's a senior. Usually they're low income.
Mhm.
You can imagine the low income person. Sometimes they're just not as healthy. They don't have the wherewithal to eat right and take care of themselves like the general population might. So it's a senior that's low income, probably lives in like a senior high rise or senior building in in the downtown of a community. That's my bread and butter patient, because guess what? That population, they're the 20% of the people that cost 80% of the healthcare dollars. And they're the ones that need educated and they need their hand held. I
Mhm.
often use the term in my pharmacy that we're a concierge pharmacy. We'll go to their houses and do COVID vaccines. We'll go to their houses and do shingles vaccines, flu vaccines. We'll take blood pressure. My delivery drivers are trained to take blood pressures if the doctor wants one or needs one, or if there's some instability in their blood pressure readings with the patient. Right? We're building a model that we're trying to assist a health plan or a healthcare provider manage these patients at home. So think about that. The pharmacy sees, your doctor may see a patient once a year, maybe twice a year if they're sickly, but that's if they even go to their doctor's appointment.
Yeah.
Number one.
So Shawn, tell us how, like, the I guess the ACOs, like there's some new ACOs. It just seems like, where do you see yourself partnering? Like, how could you help some of these organizations with these new care models? It seems like they would want to be quickly, readily receptive to partnering with you.
You would think, right? I mean, so ACO RX, so ACOR. When I created it, my fantasy was we're going to work with ACOs. This was 10 years ago. I started developing the idea. This was when the ACOs were created. Well, what happened is I feel like the ACO is like a unicorn. Everybody thinks one exists, but nobody has really seen one do its work. Right? There are ACOs. Some of the newer ones don't even have enough data to really validate that, hey, the ACO model works. But the ACO kept morphing, and they never got to a point where they engaged a full service dispensing consulting pharmacy. A lot of ACOs have a pharmacist on staff, and he helps manage the medications within the medical department, or maybe does some consulting with the patient, but most of them have a dispensing arm. And I'm not sure why that is. I think it's because a lot of patients have there's so many barriers to getting your prescriptions at various places. Certain health plans restrict you. You have to go to this pharmacy, you have to go to that pharmacy, you have to use mail order, you have to get 90 days, you can't get 30 days. So for a lot of those barriers, I think that's why ACOs tend to shy away from truly engaging in pharmacy. But they should, and I hope they do when I'm out there. That's why originally, again, that's why I created the company. We kind of pivoted when we weren't getting any uptake to just treating patients at home, and that's worked out well for us, obviously.
I just see that what you're doing, there's such a opportunity, because you are the eyes and the ears, like the pharmacy, to leverage the pharmacy. You're the boots on the ground. Like, I have a 90-year-old father, and I was with him a few days. My mom went out of town, went on a trip, and the main thing, not alone just safety. He's on a walker. He really needs help sometimes getting up, but the medications. There's no way we would feel comfortable without those medications, knowing that he's getting them. So it just seems to me, in healthcare, one of the biggest things to do to make sure older adults, like you said, aging in place at home, it is this big challenge. And so we got Greg. He's putting something else. So he's sharing that he partners with Pearl ACO, and it changed everything we do. So I'm not sure. I'm not sure his back
from the pharmacy. Is he in the pharmacy space, I wonder, or is he maybe in the healthcare space?
So Greg, I don't have eyes and ears at this point. If you would just share your background, so we would better know kind of how we could position these questions and answers. So we really appreciate your engagement. If you were just to be able to just share a little more, and we'll just wait. But anyway,
There you go. He said they love our pharmacy. So there you go. He is in the pharmacy space.
Okay. Awesome. Well,
and that's great, Greg, because I mean, think about it. It dovetails perfect with pharmacy. So, I expect ACOs in general, if they even survive, if that model continues to work, that they'll all be engaging pharmacy, because it's traditionally been the stepchild of healthcare. And now, frankly, the pendulum is going all the way back to put us in the forefront. And the greatest thing that pharmacists and pharmacies offer patients is accessibility.
Mm-hmm. Well, tell us a little bit about technology. How do you connect the dots with technology? I know you have some technology you utilize to help. Can you share a little bit about that?
Yeah, of course. So we have a lot of technology partners. Pioneer is the pharmacy system that we use to run our pharmacy, to fill our prescriptions, to connect with our patients, to talk to the insurance companies, to request refills. They drive our pharmacy. They've been a tremendous partner of ours. They're really embracing the clinical aspect of pharmacy. So now there's all kind of access points within a patient profile. In the old days, it was, here's Michael Mann, here's the drugs he's on, that was it. Now it's, here's Michael Mann, here's the drugs he's on, here's all the clinical advice we've given him over time. Here's the dates that we called his doctor. Here's what was said. Here's who we talked to. It's almost become like a CRM for pharmacy patients. So they're a great partner. Our packaging is managed. We have what is called a VBM, essentially robotics that does pill packing. Omnicell, the company that owns them. We've had the VBM since we started, and it's a workhorse. It's manufactured by a company out of the Netherlands called Global Factories, but Omnicell is the representative of that product in the United States. So that robot makes 60 to 70% of our packages every day. So it's truly a workhorse for us. Then you get into, literally just as important as filling prescriptions is the delivery software that we use, Route for Me. That we have the ability to say, we do 150 deliveries a day. So I put all those 150 deliveries in the list. I tell them how many delivery drivers are working that day, and it divides the routes based on delivery drivers, time, and location. So it kind of streamlines, and then it gives them the route that they should go, and it plugs right into Waze, the delivery, the map, the free app for maps. So, another software partner. So, I mean, technology is tremendous. The gap that I'm trying to plug in, Mike, and this is why you and I were talking just recently, I said that you go down to Vive because I went to Vive.
Yeah. So when can we open up a pharmacy at Acor in Virginia?
Yeah, sign me up.
No, but you're the you're the entrepreneur.
Well, here's the deal. Look at this. If I take my hat off, the only reason I'm wearing a hat tonight, guys, is so you can distinguish between who's Michael and who's me. Shawn's the one with the hat. If I take my hat off, you're totally clueless. I'll do the podcast. You run the pharmacy. How about that?
All right. No. I think we want medication adherency,
I'm a pro, and that's my space. And it's very exciting for me because I feel like we're on you mentioned the whole aging at home. The future of getting old for us and our generation and then next generations is aging at home. I mean, when you think about it, we could build, baby boomers are aging so fast that we could probably build a nursing home every day, and we won't have enough space for the boomers as they age.
Yeah.
So why not build a model? Number one, nobody wants to go to a nursing home, especially since
about 4%. Only 4% of the population ends up going. But hey, I want to get back to Greg because this is who he's with, and I'm not taking any sponsor dollars from Greg. We didn't do plan anything in advance, but he's with SC. He's with SC House Calls, and I don't know what SC. I guess it's South Carolina. Yeah, he's from Columbia, South Carolina, and so he's vice president of strategic growth. And so that's pretty cool. He's with a physician group, and they're utilizing, all this. So it says we are a physician practice making home visits and use our pharmacy to deliver RX to home. So that's really cool. So it'd be neat to think that there was a physician group that you could partner with too.
Yeah, no, I love the idea. I'd love to chat further with Greg. I mean, Greg, I'm sure that allows you. I mean, there's so many points in the process, Mike, that when, in our space that are billable engagements with patients, right? When a patient gets out of the hospital, physicians need to see that patient within a certain time frame. It's called a transitions of care. Transitions of care is a famous of disaster for patients. They come so transitions of care is exactly what it says. You could be going from a hospital to home, a nursing home to home, a hospital to a nursing home, but there's just so many opportunities to cause more harm than good. If you come out of the hospital, you're probably on all new meds, but as a patient, you're sick, you're tired, you don't even know you're on new meds. You may not, you probably half-assed listening to the discharge nurse.
Shawn, we're going to have to start bleeping you and have a 5-second delay with
Do you have a button? I didn't know this was that kind of stuff.
No, I'm just kidding. Hey. Anyway, all right.
But listen, the transitions of care, what I'm telling you is that there is so many opportunities there. I mean, people come home from the hospital, they take all their new meds and they take their old meds too because they didn't understand to stop them. What do you get? You get a readmission.
Yeah. I will tell you, when I had a care management organization, and when I was involved in that process, there's so many companies that are just in the transition of care. Senior Bridge was a company that was actually a Humana, then, Humana acquired it, Humana at Home. And the sole purpose was to tighten those gaps, the medication reconciliation, when people, those HEDIS measures, right when someone would go home, they would be at risk. They would have care managers come out and do all those sort of things. And the biggest thing was the medication reconciliation and getting them to their primary care doctor within like 7 days or something. I don't know if that's still it.
Yeah, you're right. Yeah. There's time frames on all that.
Yeah.
But that's a tremendous opportunity. And that's where we're looking to expand what we do, maybe embracing technology. If I can work with a physician's office, my delivery team has to deliver those medications there anyways. Why can't they bring an iPad and do a televisit with Greg's group?
Mm-hmm.
You know what I mean? Like, his doctors don't even have to do the house call. I'll facilitate the telemeeting, because think about it, this patient's probably old. They may not have internet. They may not have an iPad. They may not have even paid their cell phone bill when they were in the hospital. But if I bring the iPad and the connectivity, Greg's team can do the visit while my team is there. And then it just, I have that, again, it's the accessibility that pharmacies bring into the table. There's many things that my delivery drivers, for example, Mike, you're probably aware of this, but like social determinants of health is the new buzzword in medicine and healthcare, right? Mm-hmm. Social determinants of health. If somebody's in a situation where they don't have enough money to eat, do you think they give a crap if they take their medications? They can care less about their medications. They're trying to eat. How do you solve for that, right? If somebody's 90 and has asthma and their air conditioner's broke at their building and their landlord or the building super won't fix it for them, and they're having asthmatic episodes and can barely breathe, they don't care about much else.
Yeah.
They're worried about taking their blood pressure medicines. That they're gonna puff the heck out of their inhalers.
Yeah.
But they're not gonna go get anything new medications until they run out of their inhalers. Yeah. So I mean, if tackling social determinants of health is a huge opportunity, because that's the most expensive part of healthcare. Yeah. And the opposite side, we're all trying to figure out how to use tech to solve those problems. Mm-hmm. You can use tech to solve those problems, but you can't count on that elderly lady in that high rise to use tech, because she's not that person. So you have to, as much as we want to use tech, we have to be willing to meet our patients where they are. Mm-hmm. And sometimes that's low tech.
Yeah.
And that's okay too. In fact, sometimes we may get too techy for our own good.
Yeah. Yeah. No, you're absolutely right. My mom's 84 and she can do an iPhone, but trying to do an app is another thing. Like she can text, she can email, but don't have her use Uber on the app.
Oh, no chance. No chance.
Yeah.
You can't do it. Or they're going to rip off, and next thing you know, the credit card's charged for $2,000 for something they didn't even know they did.
Yeah. Well, I think what's good about what you're doing in this conversation we have is really, I see like a new model of care or part of care, like the community health worker. I could see could be
Bingo.
hand in hand with you.
Bingo.
Yeah. So I don't know if it would be a pharmacist tech or someone that it just seems like anyone or health plan that was looking to reduce costs, deliver those certain metrics that, improve those gaps of care, you guys would be really in line to be the first, one of those extenders almost, the care extenders to really close those gaps of care. So I look forward to seeing or hearing, in the future, if there's an evolution to you. Maybe there's a partnership with that primary care, those doctors making house calls. I don't know.
Well, so you just mentioned another buzzword in my industry, the community healthcare worker. It's kind of a new position. In fact, we just applied for a grant to get a couple of our delivery drivers trained as a community healthcare worker, get them that certificate. So now when I go to a health plan and say, look, Mr. Big, Mr. 800-pound gorilla, here's what I have for you. I'm going to deliver medications to your house with a community health worker. What do you want this person to do when they're there? Do you want them to take a blood pressure? Do you want them to do a social determinants of health screening? Do you want them to do a mental health screening? Like what is it that I can help accomplish, when I have a community health worker there? Now, the downside is that model they somehow have to pay me some sort of per patient per month management fee to help them do this. But I can assure you, in a risk reward model, they're getting the better part of the deal. But I just can't do it for the sake of doing it, obviously. So the model has to be pharmacy at the hub, as you said, like the hub, and then you wrap around all these extra clinical oriented services to help, to collect data from the patient to improve their health. Yeah. Remote patient monitoring is another vehicle, right? Greg's probably doing remote patient monitoring if he's seeing all these patients. That's the ability to put a blood pressure cuff in somebody's house and check the readings every day. Yeah. And if they get bad readings, a trigger goes off, and we call them up and say, hey, what's up? Your blood pressure has been bad. Or we call the physician, say, man, Michael's blood pressure has been through the roof a couple of days. His dog must keep barking in the background during his and his blood pressure seems to be going up. So we need to do something. So there's so many opportunities utilizing technology, but not necessarily, but using it in the right place. Yeah. Like I said, not jamming technology down at 80-year-old guy's thing, trying to get him to manage an app.
I think it's like low tech, right tech, low tech.
Yeah. I like that motto. I like that saying.
Yeah. I hope that there's more collaboration, discussion on this, and for you, not just as a business owner, but for healthcare. I feel like you're right at the point where, the fact that you were like, you're connecting with your patients at least around every 3 weeks, right?
Yeah, for sure. And then of course we're open in between then, right? I mean, we're open for them to reach out to us. That's us reaching them. Every one of our patients assume, because they're, high maintenance class of patients, they're hitting us back once a month with something else. We're getting ready. We've been experimenting with some texting functions, because today we don't, there's plenty of texting platforms. In fact, this is why I was out at Vive, to kind of see what platforms are out there, because it has to be HIPAA compliant, has to be easy to use. But, we're considering some options to incorporate texting which is the future of, I mean, even, you know, your mom's probably texting, right? You said she can use her iPhone. My
Yeah.
mom's going to be 80. My mom can text, right? So if we can get into texting for some of these people in a HIPAA compliant process, we can probably, again, maximize our connection with our patients.
Yeah. Yeah. So my mom definitely can do texting, but just not once you get to an app, good
Yeah.
luck.
Which
And
is why, like, I agree. Which is why all these people coming out with all these apps, you're just putting too much onus on you and I can do it, but we're not the ones costing the system tons of money.
yeah, I think where it's at is what I call frictionless technology, where it's like there's different terms, but it's just there. Whether it be even the best and most effective remote patient monitoring is when really the user doesn't have to do anything, And I think I was hearing some maybe not LiDAR, but different technologies that literally can get people's readings by just them being passive. I think the moment even so that's I think we're going to see some cool stuff like that, but it's probably a little too cost prohibitive at this point. But kind of going on a tangent. But tell me what gets you excited about what you do, and healthcare with where you see the future.
Well, so the future for me, right? Again, aging at home. The future is at home. Um, Many hospitals, the home visits coming back. Greg mentioned they're doing home visits. That's absolutely coming back. I think healthcare is not scalable. If you wanted to name for me one merger or mega merger that has been better for patients at ground zero, I can't name one.
Mm-hmm.
It may be better corporately, but it's never better for the employees. It's never better for the patients. So it's healthcare is intimate. It's personal. People are sick. So the future of it is bringing it back around to my level, to Greg's level, touching, concierge, being there, face to face, contact, not computer contact, phone contact, voice contact. Yes, you speckle in tech contact and text messaging, for example. But I've got a delivery driver face to face with my patients once a month.
Yeah.
So to your point, a community healthcare worker, a social worker, they got to get the healthcare. The more intimate they make it, even in Pittsburgh, they're starting to go back to these small, localized hospitals as opposed to these big, massive behemoths that they thought was the answer, 10, 15 years ago. Every healthcare, every hospital provider in Pittsburgh is all starting to open little satellite locations because I think they realize it's intimate. If you want to make somebody who's sick better, you got to really get in there.
Yeah.
You can't do that from afar. You can't do it fast. Greg mentioned a lot of these doctors' practices are, they're probably furious that, they're gauged on how many patients they see a day, not outcomes. And I know you have somebody coming up on value-based reimbursements. That's the future of it because now you got to put your money where your mouth is.
Yeah. And I think execution is everything. It's so hard to do from start to finish the execution. One thing I'm also excited about when you started talking is the hospital at home. I'm hearing more talk about that. And I do think hospitals want to make sure that they're still in business in 20 years. And I think there could be some really cool partnership with visiting physicians or physicians that go to the home, your home delivery, pharmacy solutions, and then a little more of these technology solutions that can be monitored for at-risk patients. And I imagine there will be a significant cost savings. It's just, I think that the challenge is the revenue model. As we all know, hospitals are still in the business of getting people in their beds. So anyway, that to me, I think is exciting with healthcare.
Listen, yeah, I mean, it is, I agree with you, right? Everything, I mean, you can they have sensors at home that, you can put in your parents' home that if there's a fall or a disruption in sort of the atmosphere, the sensor goes off. So then that can trigger somebody to call and say, they answer the phone. Hey, it looks like you fell. No, I dropped something. Okay, great. Take care. Or the fallen and I can't get up buttons. They've been around forever.
Yeah.
Every senior should have a fallen and I can't get up button in their house.
Oh, absolutely. I mean,
but it is technology. There is technology. There's no way we're getting through it without technology.
Yeah.
When I say we got a low tech, right tech, we agree that's kind of at the patient level. Behind the scenes and managing to give us the tools to manage a patient, by far tech is where it's at. And it's going to be revolutionized every year and every year and every year. It's the speed of light.
Shawn, can you do something for me? Tell me something that really got you excited when you went to the Vive conference. Was there any takeaway? Were you inspired? Tell me.
So number one, I was a fish out of water, right? Because, I think I have a nice little business, and I do. But the average vendor at Vive is looking for a health plan or a physician's practice, where they have 200,000 lives at stake. So a little bit, I was kind of a fish out of water, but it just allowed me to get a sense of where it's going. And what I was impressed with is I am currently trying to find my way into remote patient monitoring. And I shit you not, every other booth at Vive was a remote patient monitoring booth.
Yeah. It's interesting that you talk about remote patient monitoring. I think we are having some technical difficulties on Shawn's side, but he was just sharing how at Vive he was just really impressed with the patient monitoring, the remote patient monitoring. Every other booth was dedicated to that. And I wanted to give a shout out to a buddy of mine, Zachary Fink. He gave a little heart earlier. He is a good buddy of mine. He's an owner of Vitrac, which is a remote patient monitoring company. He's in the California area, Los Angeles. Yeah. And so he has a very successful remote patient monitoring business model, and he was early at it, and he's been really good to understand the customer and really make sure that he does it right. Well, I think what we're going to do is we might have to call it early, but Shawn, are you still with us?
I'm here, but I was losing you for a minute. You kind of cut out for about 2 minutes there. I thought you went on a 4.
I think I was here. I don't know. So anyway, but why don't you? We're gonna call it a day. So if you want to leave with the audience, you want to share something, parting words, please.
I mean, my parting words are more my excitement, aging at home. I think we're on this. How do we bring
all right, everyone. Have a wonderful Thursday. So good to have you here, 420. Take care. Best of success the rest of this